we'll start, and in case, it's interrupted, we'll continue now, finish up afterwards. So you all know that elastography has been added in most recent new technology, breast ultrasound, and it is a technique that, in contrary to the manual palpation, it is a subjective measure that allows us to have a real-time tissue measurement, which is obtained as a color-coded map representing young modules in units of kilopascals. So as you all know, in the breast, cancers tend to be stiffer than benign lesions, and elastography has been reported to improve the specificity and positive predictive value of B-mode ultrasound for differentiation between benign or malignant breast lesions. And in the fifth edition, elastography has been added as associated features. So in this lecture, I'll present to you the basic principles of both strain and shear wave elastography, the methods that we are using to interpret elastographic images, how we perform elastography, the clinical applications of both techniques, and I'll close the lecture with future challenges and take-home messages. So for breast, we have two types of elastography, the strain elastography and the shear wave elastography. And as yet, there's no color standardization. So you can see on this slide that soft on strain appears red, where hard appears blue, whereas in shear wave elastography, hard appears red and soft appears blue. So you have to be aware of the technique and the type of images that you are reviewing. Some basic information on the principles of strain elastography. So strain elastography measures the actual displacement of tissue that is caused by mechanical stress that is applied by repeated manual compression of the probe. As you can see here in this slide, this is what we measure, and the change in the anterior-posterior length during compression that is divided by the anterior-posterior length before compression. And we use cross-correlation algorithms to evaluate the echo signal data from frame-to-frame differences and deformation in tissue when a force stress is applied. So the higher the strain, the softer the lesion is, whereas the lower the strain, the stiffer the lesion is. How do we obtain strain elastography? We actually place the transducer into transverse place, so with a patient that has ipsilateral arm placed behind the head, lesion motion with respiration moves, so the lesion must be always within the image plane. Patient should be asked to refrain from speaking during acquisition and not to move. Also, rhythmic compression is applied, which is required very, very small compression. The transducer should not be angled either superiorly or inferiorly, neither to the right, neither to the left. Applying too much compression may result in image noise and should always be avoided. A quality image is obtained with right contact that does not distort the breast. The lesion position does not have to be in the center of your field of view, allowing other tissues to be included within it, and you must monitor of the B-mode image in order to confirm that the lesion is displaced only in depth and not moving in the field of view towards the right or towards the left. A great factor in generating a diagnostic algorithm is the amount of pressure that we apply during scanning, and please remember that you must avoid the pre-compression when obtaining strain elastography. In all manufacturers, we have the B-mode is displayed on the left, so we have a dual display, and on the right, the elastographic data. How do we know that the appropriate compression is applied? Actually, in most manufacturers, there is a display bar, as the one you see here, and the appropriate vertical amplitude with moving a probe is between 1 to 2 millimeter. So an appropriate speed, you need to apply appropriate speed for vertically moving a probe would be 1 or 2 per second, as you can see in the indication here. When you apply elastogram, you must understand the quality of image, and in strain elastography, in order for the compression that has been applied that is proper, you must visualize the subcutaneous fat stripes of green over here and red, and the pectoralis muscle must be displayed with uniform blue color. The methods that we use to interpret strained images is the 5-point color scale called the Tsukuba score, also the elasticity called the index value, as well as the ratio of the lesion stiffness to fat. And this is the 5-point visual color scale, the Tsukuba score, where you can see here, starting with score 1, the lesion is soft and appears green. Score 2, the lesion is soft and part of it is soft, part of it is hard. Score 3, the lesion is hard and less soft. Score 4, the lesion is harder and the same appears with the same size as on the elastogram, where the score 5, the lesion is hard and larger in size compared to the elastogram. Additionally, in complicated cysts, what we have is many times we receive the bullseye artifact, which is a layer color pattern of blue, green, and red called the BGR artifact. Few words about the index value. The elasticity index is defined as the value between 0 and 6 is measured within a drawn region of interest, ROI. It is automatically or manually traced on the lesion of interest, and the higher the index value, the stiffer the lesion is. Here is a case of a complicated cyst where you can see the elasticity index score is only 1, so it is suggesting of benign lesion. In contrary to this lesion, you can see the stiffness appears as blue. This is strain elastography. The index score is 3.3. This is a stiff lesion, and this is even stiffer. The elasticity index score is 4. You can see the lesion, and also the B-mode. The B-mode criteria are very important in every case. Another method is the E ratio, which is the index ratio. The E ratio measures the index ratio between the indexes calculated in 2 different ROIs in 2 different regions. The user provides 2 ROIs and the system calculates and displays the E ratio between these 2 lesions. This ratio is numerically evaluates how many times stiffer the area, the target mass, is compared to the subcutaneous fat. There's a variation in the literature, and between different manufacturers. The cutoff value is 2.5. And in this slide, you can see the higher probability of malignancy according to the strain ratio. The cutoff point of 2.6 is there is approximately 0 probability of malignancy, whereas it increases when it's more than 5.2, there's a high probability of malignancy. So the target point of the tumor, remember, should not extend beyond the interior of the tumor in the P mode. The ROI should be taken the same depth as possible in order to limit errors that are caused from compression. And please remember not to use the very soft signal sometimes seen adjacent to lesions, because this might be an artifact that will artificially elevate the fat ratio. As we proceed now with some basic principles of shear wave elastography, in this slide you can it demonstrates how the shear wave elastography functions, where the shear wave elastography is based on the principle of acoustic radiation force. a transit pulse is generated, inducing transversely oriented shear waves in tissue. Some tips for implementing shear wave elastography. The probe should be kept still with no pressure, allowing the image to build up for about 10 seconds. Obtain 3 acquisitions per lesion to reduce variability. Keep the row as small as possible in order to allow measurement of the stiffest tissue. Elasticity of the tissue can be measured in meters per second or in kilopascals, which is the unit of pressure, providing quantity information. And remember that many cancers may not be uniformly stiff, but have a halo of peritumoral stroma stiffness. The amount of compression that is applied is very important also for shear wave elastography. And note here that the fat layer over here should display sufficiently blue and not be orange or red, because you might get a wrong measurement. And the ranges of the maximum elasticity value according to the maximum elasticity color scale here starts from 0 kilopascal up to 180 kilopascal, and the color scale is classified into 3 categories. Soft elasticity appears as dark blue or light blue. Intermediate elasticity appears as green or orange, and hard elasticity appears as red. And in this slide, you see the higher probability starting from 0.4% for lesions that appear to be soft with low kilopascal between 0 up to 72, and see how much it increases up to 81.8% for lesions that have high kilopascal up to 180. This is the visual classification of shear wave images. This is a negative finding. It appears dark blue. It is homogeneously. Now in this slide here, you see vertical strip pattern artifacts. This is not a good quality image. Another case, positive findings. You can see here the localized color area at the margin of the lesion, and also in the bottom here the heterogeneous color areas in the interior of the lesions. Both of these lesions were cancers. There is correlation between the size of the lesion and the mean stiffness, and according to the literature, the larger the lesion is, the stiffer it might be. Also, there is a correlation between the mean stiffness of the lesion, histological grade of cancers, and large cancers with high histologic grade, with lymph node involvement and vascular invasion. There is an association with high mean stiffness values. Also, the larger the variation in the mean stiffness found within different size of groups, within cancers within 1 centimeter, between 1 to 2 centimeters, and cancers that appear to be more than 2 centimeters have been suggested that intrinsic tumor biological factors are causing variation in tumoral and peritumoral artifacts. Some cancers may appear as the black hole sign, phenomena sign on shear wave images. This is due to the attenuation of the energy of the shear wave at the margin of the lesion, or it might be due to the interior of the lesion. It's due to the fact that it's very hard, and because of the velocity of the shear wave is high. So what about the performance of shear wave? Cancers that appear to be large, or there is an increased breast thickness, we have a higher chance of receiving a higher false positive rate, whereas cancers that are smaller in size or they're localized deeper in the breast, we have a higher chance of receiving a higher false negative rate. Note that the ROI is very important, that it is at the same level. Also, please remember that it's important to keep large field of view in order to maintain more constant color map. If the lesion is larger than 2 centimeters, please select only an area of the lesion that is more suspicious, it's more stiff, it's more blue, or it's more orange or more red. Also, the amount of gel is important. Please apply generous amount of gel when performing elastogram. Also avoid any compression, deep breathing, and body motions of your patients. The range of ROI to exclude the skin and also the chest wall layers. And also the lesion, the size of the lesion, the depth as well, the breast thickness are other factors that influence the quality of the elastogram. This is a case where on B mode you can see a very suspicious finding in density margins, angulations. However, because we did not select the correct area and we did not measure the appropriate area, we received a very low kilopascal, only 16. It was the measurement, whereas in the second measurement we received 121 because the ROI was located in the proper location. So the clinical applications of elastography is actually the possible change that we can perceive in management, in clinical management. And there are many studies that have shown that elastography may have a positive impact on the short-term follow-up to routine follow-up. So therefore, to downgrade BI-RADS 3 lesions to BI-RADS 2 lesions. We have to be very careful here. In order to downgrade BI-RADS 3 lesions, all your lesions must be very soft on elastography and must have strictly typical benign BI-RADS criteria, and we'll hear more about this from Dr. Mederson tomorrow. Please remember that another indication of elastography is to downgrade for BI-RADS 4A lesions to BI-RADS 3 lesions, and you have to be very careful, either if you want to receive a highest specificity or you want to avoid the false negative rate. And you can read more on this article by Dr. Berg. Another indication is upgrading BI-RADS 3 to BI-RADS 4. Lesions that are hard on elastography should always be considered, this indication should always be taken into consideration apart from the BI-RADS criteria. Note that when assessing small lesions, softness should not prevent you from biopsy of a suspicious lesion, because small lesions tend to be softer even if they are cancers. Also, another indication is to upgrade BI-RADS 4A to BI-RADS 4B, so we feel more confident about our classification. And three-dimensional zero wave elastography has been developed, which provides volumetric color-coded elasticity maps of tissue stiffness in a single acquisition, and according to literature, this is more used to follow patients that are receiving neoadjuvant therapy. There are some limitations of strain elastography, and those are that the data acquisition, interpretation, and elasticity images are largely dependent on the examiner's experience. There is a significant inter-observer variability. Elastography is not indicated for the evaluation of post-operative changes versus tumors. Also, according to literature, there is a variability of false negative rates. You can see here among the different articles from Vera, from Sarah Vinicobre, from Dr. Berg, Dr. Jung, Dr. Yoon, there is a great variation, and it depends on the cutoff point of kilopascals, and of course, the lower the cutoff point, the lower the false negative rate. However, bear in mind that small size of cancers, less than ½ centimeter, DCIS lesions, as well as soft cancers, such as mucinous carcinomas, we might receive a false negative measurement. Other limitations of elastography, they are for lesions that are located superficially, as the case here. Also for post-traumatic fat necrosis due to the development of fibrosis, you might have stiff area, which is not a cancer, but just a reaction. Also, some fibroadenomas, if they're there for many years, they may appear stiff, whereas some circumscribed cancers may appear soft. Therefore, it is important always to consider the B-mode ultrasound descriptors and decide upon them and just receive more information from the vascularities we heard from the previous lecture, as well from strain or shear wave elastography for the characterization of breast lesions. And this is a tiny cancer, which appears blue on shear wave elastography, but it was a cancer. And you can see here the suspicious findings on the B-mode image. So closing up this lecture is that elastography, yes indeed, it can increase the specificity and positive predictive value of B-mode ultrasound. It can downgrade 4A lesions, but it can also upgrade biroid stream, can provide an increase in diagnostic confidence. It can provide more accurate use for those that are performing needle core biopsies. It is particularly useful for complicated cysts. Also, more than 90% of cancers that appear in ultrasound have a mean stiffness of more than 50 kilopascal. When assessing small lesions, softness should not prevent biopsy, when otherwise it seems like it is a suspicious lesion. Clinical management should be based on its more suspicious B-mode features, in correlation, of course, with elastography, and a higher suspicion lesion on B-mode should be biopsied regardless of the elastogram appearance. The future challenges is to standardize the color display across elastographic systems to decrease the inter-observer variability, reliability of elastograms, especially for the lesions that we are following up, they have probably benign features, and also to assess the correlation between the tissue stiffness and the prognostic factors of breast cancer. At this point, I would like to acknowledge my good friends, Dr. Ellen Mendelsohn and Dr. Spiros Lazaru, for providing some slides and some shear wave images produced by Supersonic System. And I would like to thank you, the European GE ultrasound team, for providing their technical support on Logic E10 system, so I was able to provide you some elastographic images. Thank you all for your attention. So we managed to finish. Maybe the surgery is running late, I think. Are there any questions? Yes, please. Good morning. Yes. So
I've biopsied her. Can you hear me?
Yes.
So I've biopsied her, and of course the result was a fibrocystic tissue. Now, in instances like this, do we have the right to go back to just feel on morphology that we are happy with the B-mode appearance and neglect what elastography says? Or do we still have to take into account what elastography has suggested, and because of its stiffness, again, biopsy?
Yes, thank you very much for this very interesting question. So it is true that some cysts may appear in the periphery stiff. I don't have an answer for this. And now regarding the next step, what would there be in order to feel more confident and to avoid any false negative results? Is that I would focus on the B mode. If it is a typical oval-shaped cyst and is not round, if I have a patient that is not a BRCA1 or BRCA2 patient, or this patient doesn't have a very strong family history, a sister or mother in young age, I would not proceed with a biopsy.
Would you call it a BI-RADS 3 then, or would you refer back to BI-RADS 2 and MS?
Well, I'm not working in screening. I would stick on BI-RADS 2, personally.